Everybody, this is Patricia Potter with Kirkland Solutions. Thank you for joining today. This is the May 28th Intermacs and PDmacs User Group Webinar. Thank you all for joining. It's been a little bit since we've met, so we have kind of a full agenda for today. We're just going to go through some STS updates and then talk a little bit about the new Coumadin fields that have been added to the medication form. Talk a little bit about discharge dates and major bleeding, and then talk a little bit about AQO. And we should have some time at the end of our meeting to have an open discussion, and you can put your questions in the Q&A box and we will go through and answer all of those. So if you have any comments or questions throughout today's webinar, go ahead and put those in the Q&A box. Just real quick, I just wanted to say that back in, I believe it was in February or March, we had two individuals join us to talk about how they have used their Intermacs data at their site to drive a quality improvement project. So that was really great. That's something Nancy and I are hoping that we can have more of this year. So if you are using your Intermacs data to drive any projects at your site, we would love to hear from you. So please reach out to myself or Nancy and we can put you on a future webinar to share. I know everybody loves hearing about what's going on at other sites and how they're utilizing, their dashboard, live data downloads, quarterly reports. So it's always a great discussion to have. So if anybody is interested in it, please reach out to us. It's just casual. It would be on like one of these webinars with just the Intermacs community. So we'd love to hear from you. And I don't think I introduced everybody on the call. I'm sorry, my slides might be a little bit out of order. I just wanted to say today from STS, we have Nancy Honeycutt, Leanne Jones, and Emily Conrad. And then from the Kirkland Solutions team, we have Jeannie Ann Love on the line, John Pennington, Maceo Cleget, and Brandon Singletary. So thank you everybody for joining. I'm sorry that my slides might be a little bit out of order. And then I did want to mention June 30th, so the end of next month, the Q1 2025 reports will be coming out, and that had a data entry deadline of April 30th, and those reports will be coming out the end of next month, so stay tuned for those. Our next webinar, so we'll have another user group webinar on June 25th at 1 p.m. Central, 2 p.m. Eastern. And then it's been a little while since we had a reporting webinar. I think we had to cancel the one in April. So our next reporting webinar, it will be back up on the website, but it's going to be July 17th at 2 p.m. Central, 3 p.m. Eastern. And then it will be every 3 months from there. So that will be July 17th. And then we will be getting ready to kick off the 2025 STS audit. So the notifications, if your site is selected for audit, those notifications will be sent out most likely next week. And you will be the site administrator and the physician representative at the site will be notified via email. So if you think your site may not be up to date on the current contact information for the site administrator or physician representative, or if those roles have changed, you can complete the STS participant form. And I think Nancy just put a link to that in the chat. So if you need to make any changes to contact information at your site, that's the form we use. Anything else? Oh, and also, if you are notified that you have been selected for audit, there will be a webinar specifically with the audit company, HMS, and all the other sites that are being audited. So it will be a webinar directed for you, and they'll go through all the steps and what to expect. Emily, anything else that I missed on the audit?
No, that's good. Yeah. No further updates. But if you have any questions about it, you can reach out to myself, Emily Conrad, at econrad@sts.org.
Great. Thanks, Emily. All right, and then I just wanted to talk about the Coumadin fields. So as many of you have noticed, we have added some child questions to Coumadin on the medication form. So we're now collecting the date that Coumadin was started, the lower and the upper limits for the current therapeutic INR range, as well as the date the patient was first within the therapeutic range. So first off, I just want to say that if the patient has been on Coumadin for quite some time and you're working on a follow-up and it's been years and you're not sure what date it is, we don't expect you to go back and retroactively locate the date. So putting unknown is completely sufficient. If this is a new drug, then yes, we do want to know, or if it's a new implant and the patient is newly being started on Coumadin, we are interested in when that was started. So you would just enter the date. And then we have two fields, one for lower limit, one for upper limit. And that is just looking at the current therapeutic range, not specifically when the Coumadin was first started. And then the date, the goal was first achieved, that is looking at the date that the INR was first in the therapeutic range. And again, if this is a patient who's been on Coumadin for many years, it's okay. You can just enter unknown. Do you want me to just stop there? Because I know we had a lot of questions around this. Nancy, do you see if anything specific is in the Q&A regarding Coumadin?
I'm not seeing anything right now.
Okay, all right. Well, if anybody has any questions on that, feel free to put them in the Q&A and we can talk about it. And then the other thing was we were doing some integrity checks and looking at discharge dates. So I just wanted to just do a little bit of education on discharge dates. We collect discharge dates on the rehospitalization form as well as on the implant discharge form when talking about the rehospitalization form. So for example, if a patient is readmitted for a transplant, the discharge date for that transplant is the date of the transplant, not the date that the patient was discharged from the hospital from their transplant. If anyone has any questions about that, go ahead and you can ask it, but I just wanted to just remind everybody that the patient's time in Intermacs stops once the patient is transplanted, and so that is considered their discharge date or their discharge from Intermacs at that time. And then also, I wanted to mention that just to double check your dates, we've seen some dates where the discharge date is prior to the admission date. So obviously those are just probably typos or mistakes, but just double check your dates when entering admission date and discharge date.
Patricia, we did have a question come in.
Okay.
Actually, if you want to go through this next slide, it was pertaining to the Coumadin. We'll get back.
Okay, I'll just finish this one. And then we also do collect discharge dates on the implant discharge form. So if a patient dies during their implant hospitalization, the death date is considered their discharge date. And this also goes to say that if the patient dies during their implant hospitalization, it is still important to complete the implant discharge form. And that is part of our monthly integrity check. So if you do forget, you'll just get an email from me, reminding you that the patient has an outstanding form. But yes, if the patient dies during their implant hospitalization, the death date is the date of their discharge. Same with transplant. So if the patient was transplanted during their implant hospitalization, the discharge date is the date of their transplant, not the date they were discharged from the hospital from their transplant. So I'll just stop there for a second and we can go through some of the questions.
Yeah, so the first question is related to the Coumadin. What if the limits are changed? Should we put in the date that the new goal is reached?
Okay, so just stopping there for a second. So I just went back to the form so everybody can see the fields. So if the limits are changed, we definitely want to know the current. So during this follow-up, the current lower and upper limits. The date the goal was first achieved, Nancy, I may lean into you. I feel like with the wording, the date the goal is first achieved, that would be, well, the goal.
Just
Yes.
thinking about this for a minute.
Yeah, no, I'm just thinking out loud and I'm thinking that, so if the goal is 2.5 to 3.5, then yes, that would say we do want the date the patient was now in the current range. Would you agree, Nancy?
Yes, yes, I agree.
Okay, because we're talking about the goal, and if the goal is 2.5 to 3.5 and they're now 2.8, we want to know what that date was. All right, Sherry, I hope that answers the question. I hope that, and we can add this to the user's guide. We can even put it in the FAQs, and we can even update the, if you've noticed that we put an announcement up on the Intermacs login page, just because this was new information before we had a webinar. So I'm gonna put that there. Is this
And
the
y-
range for each
yeah.
patient? Yeah, so the range for that current patient. You know, like
No,
specific for that patient as their goals are tailored for everybody. And then Deborah, I thought that the date the goal was achieved was when they initially started Coumadin. That's kind of what Nancy and I were discussing. Should it be should it be the date that the patient initially started Coumadin, or would it be the date the INR was first in therapeutic range? And I believe it should be, if we're talking about the goal, it should be when the patient reached the current goal. Correct, Nancy?
yeah, this is the medication form on the follow-up.
Yeah.
So if the limits changed at some time between the last follow-up, you want to know the date the goal was achieved. The current goal, current limit.
Current goal, right. And so just to think a little bit outside the box. So say the patient was on Coumadin, they stopped Coumadin, say they were having some bleeding, and then they restarted. You would have a new start date. So then you would enter that date. Even though the patient had been on Coumadin for 3 years, they stopped it for a time and then it was restarted. You would then now have a start date. Yeah, no, we don't expect you to, Carl, we don't expect you to go back and enter any retrospective data, just if you currently have it. I have been using the date the Coumadin was started. Yeah, so for this, Lori, for this first field, the date started is the date that the Coumadin was started. I also thought the lower and upper limits are INR results during date range of the report. So the lower and upper limits should be the current INR limits. So if it has changed, you know, so say on the 6 month, it was 2 to 3. And now when they come in for their 1 year, it's 2.5 to 3.5. You would use, what are the current limits for this, for the Coumadin during this follow-up period? And if it adjusts and it changes during the follow-up period, use the range that's closest to follow-up. But it says first achieved. The date the goal was first achieved, but it's referring to this goal, the current goal.
Do you want me to
Sure.
unmute?
Yeah, that works. Okay. Thanks, Deborah.
Hi, I'm so sorry. Can y'all hear me?
We can.
So, looking at it, this is how I interpreted it. And because I'm a little crazy. But so the lower limit, I was thinking like, okay, you have a 6-month period of INRs. I was thinking that the lower limit was the INR that was the lowest at that time, and the upper limit was the INR result that was the highest at that time. Not the actual goal of what you want to achieve with your INR, but the actual results of the INR.
Okay. I can see that. So we have actually, and I don't know if, I know Sherry's on the call with some PDMax people. We have collected these fields for maybe a year or two, maybe even a little bit longer in PDMax. And so that's kind of, if everyone's on the call wondering like, where did this come from? Why did they just add this in? It was fields that we previously collected in PDMax. It's a little bit different of a patient population. So I can understand, Deborah, what you're saying. The intent was for the therapeutic, for what is the range and when did we get into that range? And we probably need to clarify this and make the language a little bit better, but that's where these fields came from.
Thank you.
So
Yes, we will get some clarification. John, if you want to take yourself off mute, you can go right
yeah, I'm
ahead.
off mute now, right? You can hear me now, right?
Yeah.
Okay. So the lower limit is what the lower so the patient's goal is 1.5 to 1.8. This should be 1.5 and the upper limit should be 1.8 because that's not clear here.
Yes.
That's what we're looking to collect. Yes.
Is that what you want to collect now?
Yes.
So the lower limit is the lower range of the patient's INR specific goal, and the upper limit is the upper limit of the INR, patient's INR specific goal, i.e. 2 to 3. The upper limit would be, the lower limit would be 2, and the upper limit would be 3.
That's correct.
And then when did you get into that?
And then the date the goal was first achieved is the date during that follow-up period that you reached goal. So if the follow-up period is from January 1st to July 31st, right?
Yeah.
Then that's the 6-month period. The date that first goal of 2 to 3 was achieved, which doesn't make sense to me because what does that matter if on January 1st your INR is 2.1, so you would put in January 1st, right?
Yes.
But
Or
what does that
if
matter if January 2nd it was 1.1?
Agreed.
So that's why I don't know how you're going to use this data because it doesn't tell you much. It just tells you when you hit the goal. It doesn't mean that you would maintain that goal. So you're asking us to do a lot more work for, unless you could explain it, a insignificant gain here. So what are you going to do with this?
And John, that has kind of been the discussion amongst us since these fields went live, what are we intending to do with this data? We are working to revise some of our AEs and some of our forms with the cardiologists and surgeons. And I think that this is something that needs to be, brought to their attention to, see is this something that's really useful, all of these fields, and what do they plan to do with the data? Like I said, it came from PDMax. We've collected this for a little while in PDMax, but that patient population is different. Patients are, on devices a lot, the term of the devices is a lot shorter than your max, the adult population. So we'll get some clarification on this, but I did want to just, make sure everybody knew what the intention was for each of these fields and how to collect them in the time being.
And I missed the first part. The date started was the date the patient started on Coumadin.
Yes, and we don't expect you to go back, you know, retrospectively. So you
But like
can,
if I know I start every patient on post-op day 2 on Coumadin, that's easy because it's just, you know, implant date +2, and that's that. But you were saying if you stopped Coumadin and then resumed it, you want that date? I mean, that's
yes, if you have it, yeah. So say patient stops it for, you know, a month or two and then resumes, then yes, you want, when did they start it? What's their limit? And when did they get into a therapeutic range?
okay. So lower limit to upper limit is their goal, and then the date they got to goal for that follow-up period.
If you
All right.
have it, yes.
Yep. Okay. Easy enough.
Okay. All right. Yeah, Lori, I think you'll see the documentation within the notes of what the intended goal is. Then why are there choices in the drop down for if you don't know it, if you don't know what the intended range is? No, Carrie, this data is not telling you how long that they've been in the therapeutic range, just when did they get in the therapeutic range. Yeah, I agree. Yeah, good data for initial implant, Sherry, but changes too often throughout the year on the adult patients. Yeah. And we had kind of talked about that, you know, this mostly would apply to maybe like the 1 week, the 1 month, you know, initially early in implant in the adults, you know, when the Coumadin is first started, but right now it's on all the follow-up forms, but maybe in the future we will change it to just those initial follow-ups. All right. Hi, Sarah. Will the start date carry forward from form to follow-up form? It won't. We don't have any fields other than I think address that carry form to form. We've talked about it, and you know it's just not always a good idea to carry a lot of information from form to form because sometimes it can get overlooked. If the range never changes and the patient is still therapeutic, do we use the original therapeutic date, or do we need to enter a date within the follow-up, in the current follow-up? That's a great question. I would use the original therapeutic date. Nancy, what do you think on that?
I agree with that.
Okay.
Yeah.
Yeah, Sheila, this question only seems appropriate for the 1 week follow-up and not the remaining. Yeah. Specifically, the date started and date goal first achieved. Collecting the goal range would be collected on an ongoing basis, but not the date fields. Yeah, we talked about that too, that maybe that would be most helpful. So anything can be revised. We'll talk with the doctors and see, you know, the physician leaders and see what they think would be most beneficial. But we did talk about that, just maybe doing the goals. Please go to the ST button drop down. I am not on the, Deborah, you can come off of mute if you want. I'm not on the website, and this is just a screenshot of it.
So on the lower limit, when you do the ST drop down, it says
Yeah.
lower, like there's numbers. So if I wrote 1.2,
Okay.
it would say lower than the minimum. So I can't put a number in. And the same with the upper limit. So if I say the upper limit is 4,
Yeah.
it won't let you put that 4 in. There's the drop down that says higher than the maximum should be.
Okay. So we do put guardrails in there, so you know we don't get, you know, just typos and you know numbers that don't really make sense. Maybe we need to adjust the limits for that box.
Thank you.
I don't know, maybe we'll put it up to like 15, maybe. Yeah, thank you. I'll make a note to do that.
Well, no one's goal is gonna be 15.
True. I'm just thinking like an INR that came back. Yeah, you're right.
But but again, this is the goal, the
Right,
prescribed
the
goal.
goal,
This ain't
not
what the
just
INR
what,
actually is.
right. Okay. So I'm sorry, Deborah, what did you say it was? It wants between 1.2 and 4?
That rationale, I was just thinking logically that because that wording is in there, that the lower and upper limit, logically, it looks like the lower limit should be the lowest INR that was in the time frame, and the upper limit is the highest INR that was in the time frame, because there are people that come in with an INR of 5. So I would think that that's what they're looking for. What was the lower INR during this time frame, and what was the highest INR during this time frame, to look at possible how Coumadin is managed.
And I think I see what you're saying, but I think that what you're seeing in the drop down fields was just that we put guardrails in there for the goal so that it
Gotcha.
wouldn't be outside, it wouldn't be, a typo.
Gotcha. Thank you.
Yeah. Oops, did I just? Cindy, so initially, how long did it take to get in? Yeah, so say you're doing a new implant. We're interested in when did the patient first meet their goal? Hi, Rosalind. How does the PDMax participant use this limit and goal achieve data and what for? I'm not sure that we have had any analyses done yet with this. But we have I believe it's called the antithrombotics form in PDMax, and that is what this was initially added to. Carol, I believe it has been updated. It may just be the date on the website needs to be updated. I believe it was updated maybe a month or 2 ago, but I will be doing it again in June. Because usually we'll put like a timestamp of when it was last updated, and I think the actual document has been updated, but not the date. I interpret the date goal first retrieve was from when first on Coumadin initially, if they are looking for time to therapeutic. Yeah, Colleen, that was kind of what we were talking about initially. And I think that because it's saying goal and the goal can change over time, we're looking at for the current goal of say 2 to 3, when did they first get in that range? Yeah, Sheila, we can change the language on the form for sure. If you think that would be most helpful to put goal instead of limit. Yes, the therapeutic goals, Lori. Yep. Betty, in the meantime, while you get definition for how should we record it, it would be a lot of work to. Okay, so for the time being, we'll leave it just how it says on the announcement page, so everyone is recording and coding the same. The date started is going to be the date the patient was first, the date the patient started on Coumadin. So when did they first start on Coumadin? The caveat to that will be if the patient stopped taking Coumadin for some time and then restarted, we want to know when was the patient started on Coumadin. So you'll use that date. The lower limit and the upper limit are the lower and upper limits, or the goal of the therapeutic INR. So if in the medication orders you see that the goal therapeutic range for the INR is 2 to 3, the lower limit is the 2, the upper limit or the upper goal is the 3. Date the goal was first achieved for the current INR goal. When did the patient first get into that therapeutic range? So I hope that clarifies for everybody. This webinar will be recorded, so if you get confused while you're working on your forms, it will be recorded on the STS website and you can reference it back. We'll leave the announcement up on the Intermacs login page, and you can reference the instructions on there. All right, John. So the date they got into therapeutic range during the follow-up period or since they started. So if we're talking about follow-up period and we're talking about the current range, we're looking at when did they first get into that range. So if they were in range the entire, like your example, January 1st to July 31st, if they were in range that whole time, you would have to put unknown, correct? Because they were probably in goal prior to that. Nancy, what do you think?
Yeah, if they're in range the whole time or the follow-up period, they were probably in goal prior to that. And that would require going back into the record. And we don't want you to have to do that. So you have the option to choose unknown.
Doesn't make sense. So it's the date the goal is achieved for that follow-up period, because
Or that INR range.
right. So it's not the date they were achieved. The goal was achieved since inception of Coumadin, potentially 5 years ago. It's the date the goal was achieved during the follow-up period. I'm assuming, and that's what you said before.
Yeah.
So it's
Yes.
the date the goal was achieved during the follow-up period, because otherwise you'll be looking back up to 10 years.
Right. And we don't want you doing that.
Right. So it's just the date the goal was achieved during the follow-up period.
Yes.
That's how I worded on the form.
Okay. Yes, that's correct.
Thank you.
Hi, Carrie. Date started is the first date started and the lower and upper limit is within the specific follow-up period. The date started is when was the patient started on Coumadin? That's the date started. And the lower and upper limits are, yes, the lower and upper limits for this specific follow-up period. Very labor intensive. Yeah, we don't want you going back and looking, to see when the patient was initially on Coumadin. If it's a patient that's, had their device for quite a while and they've probably been on Coumadin for a while. So if you have that date, for like a new implant or a patient who is newly starting on Coumadin, we'd love to have that data, but we don't want you going back. And then, for example, if the patient is admitted for dental extractions and the Coumadin is withheld, do we then start this process again? Yeah, if the Coumadin is stopped, for a week or two, then yes, we do want for this, follow-up period, was it started? And if so, what was the start date? Okay. I hope that answers the questions. But if not, we will talk about it on another webinar. And if we get any more guidance or direction from the physicians, we will let you know. Oh, we've got another question. That wasn't clear. The medication form states, mark whether the medications listed are used during the follow-up time period. Yes, no, or unknown for the rest of the meds. Choose unknown for long-term in-range meeting goal patients. Do not actually put the first date of the follow-up window. Sorry, Rosalind, I'm not sure what you're referring to. So mark whether the medications listed are used during the follow-up time period. So yeah, so you consider all medications from the previous follow-up. So you would say, yes, the patient has been on Coumadin since the last follow-up. Then Sarah, I thought I understood, but the last question is throwing me off. We want the original date the goal was achieved or the date it was achieved in this follow-up window, assuming the range is the same. I'm not sure I'm understanding the question. We want the original date the goal was achieved or the date it was achieved during the follow-up window. We want the date that it was achieved. If the range is the same. I think we need to know for sure if this is for what the date during the follow-up period the patient was in range, or what is the date the patient meets the goal for that specific goal, regardless of the follow-up period. We just want to know for this range, when did the patient first meet this goal? That's what we want to know. Discharge question. If a patient is discharged from the hospital, goes to rehab, what discharge would you use, hospital or rehab? So if they're discharged from the hospital, you would use the date the patient was discharged from the hospital, not from rehab. You would have to put unknown if they were in range the entire time. Because it would be outside the window. Yeah, Rosalind, you can be unmuted.
Yeah, I think your last sentence just clarified it, but earlier on the call it was confusing. So if the patient, my question is, if the patient has already met goal the entire follow-up window, we're
Right.
unknown.
Yes.
We are not to pick the date of the first day of the window and hand type in a date.
Correct.
Thank you. That was the clarification. Thank you. You can mute me.
All right, Lori, I have a question about history of GI ulcers. Would that include any type of GI bleeds such as AVMs? Someone asked about esophageal varices in the FAQ, and the answer was yes. To include yes. Yep, you include them as part of the GI system. And actually, I'm going to talk in a second about bleeding. Okay, so major bleeding, when you go into the major bleeding form and you answer for an adverse event, the patient is having major bleeding, you answer the first or the top level question, did the patient have major bleeding? And you select yes. And then we get to the source, cause, location of the bleeding. And these are the current answer options that we have for the source location of the bleeding. If you are not seeing your location within this list, we have other specify. So that will prompt you to then type into a text box the location of the bleeding. And so we were just recently looking at, what other locations are in that other specify that we're probably missing and we need to add to this list. And so we looked at those, and I just wanted to just highlight on some of this. So we noticed there was kind of a trend with GI bleeding, source not identified, GI bleeding unknown, and these are examples of what was typed into that text box. And so I just wanted to point out that we do have an option for GI unknowns. The patient has melena, or they have guaiac positive stools, and it's clear it's, GI bleeding, but, they go for colonoscopy, or, they have a study done and the source was not able to be identified. We do have the option for GI unknown, so you don't have to put that in the other specified text box. And then we also noticed lots of nosebleeds are being typed in there. And I just wanted to point out that we do have the ENT dental selection. So nosebleeds would fall under ENT. And then also there was a pretty good sized number of intracranial hemorrhages. So I did want to just remind everybody that any kind of brain bleeds, hemorrhages, those fall under neurodysfunction for Intermacs purposes. It's not considered major bleeding. That would fall your subarachnoid hemorrhages. All of that will fall under neurodysfunction, not bleeding. So just a reminder on those. And then, and I did want to say, we will be adding driveline exit site to the list of options. And major bleeding is one of the adverse events, along with a few of the others that are being updated and will be updated in live next summer, like around July 2026. So we will be adding the driveline exit site. And that's kind of what prompted this reviewing of locations. So we are looking at all of those, and we will make some additions. We talked about maybe adding for like bleeding around like PICC line insertion sites, maybe adding something for lines, catheters, something like that. All right. So Nancy, let me turn it over to you so we have enough time to talk about AQO.
All right. We actually have 3 questions in the Q&A. So before I get started with that, let's go over these. So John is asking, do we change comorbid conditions on follow-ups? Like if in the case of chronic renal disease?
So yes, so the comorbidities form, we've talked a lot about, should the comorbidities, kind of like the previous question, should the conditions carry over form to form? Do we have to keep entering them? And we do want you to review, what the patient's current comorbidities are. So if anything changes, yes, please do, accurately document that to reflect any changes that may have occurred. John, let me know if that didn't answer your question. What is considered major bleeding? So, Lisa, we have on the Intermacs website on Kirkland Solutions under appendices, the very first appendix, I'm assuming is probably Appendix A, has all of the definitions, and you'll see the definition for major bleeding on there. But basically, major bleeding is any bleeding. So we type them out into subtypes. So a type 1 could potentially be bleeding that the patient didn't even need to seek treatment for. So the patient has a nosebleed and they stay home. They don't need to, go into the ED for packing. They don't need to call their VAD coordinator. It's just something that they were able, any kind of bleeding you were able to manage at home. And then there are, from there's, different types based on how severe the bleeding was and how the bleeding affected their hemoglobin. So there are different types, but basically it's any type of bleeding. But the definition is, I think it's under Appendix A. And then if you were to just open up a major bleeding form and you click yes to the top level question, was there a major bleeding event? You'll see the different subtypes, and there is helper text that you can hit show more and hide that will kind of expand on what the definition is for each of the subtypes. Will primary overall survival be risk adjusted at any time soon? Brandon, do you want to take this question? I know, last year at AQO, we talked a lot about risk modeling and survival. Do we have a time, or Nancy, do we have a time frame on this, or?
I don't have a current time frame. I know that the Intermacs workforce is working on this project for this year, so more to come with a time frame.
Yeah, I mean, we had the risk model published. That was kind of phase one, and then I think the next phase, from my understanding, is just kind of getting feedback, getting sites more familiarized with the process before the next step. But again, as Nancy mentioned, the task force is kind of heading that up.
And Carrie, all of these revisions to the AEs, all of that is being considered as well with that timing. But like I said, the revisions to the AEs will probably be live next summer. So not too soon. And that will go along with our Intermacs platform upgrade as well.
All right. So I guess with that, we're ready to talk about AQO. The 2025 Advances in Quality and Outcomes, a Data Managers Meeting, otherwise known as AQO, is going to take place for Intermacs and PDMacs on September the 23rd. You can go to the next slide, Patricia. So what is AQO? So this is your opportunity as data coordinators and data managers to learn about data collection using case scenarios, and also talk about driving quality improvement. So the format for AQO this year for Intermacs and PDMacs is going to be a webinar, plus we will have content on a virtual platform. The audience for AQO is you, everyone on this webinar, data coordinators, data managers, abstractors, also site administrators, and anyone else who is interested in learning about Intermacs and PDMacs. We're currently working on our program, and we want to provide the content that is pertinent to you being able to do your job. We also are accepting abstracts for presentation consideration on the webinar, and also on the virtual platform. The abstraction submission deadline is Monday, June the 2nd. And you can find out more information about submitting an abstract online. And currently, we do not have any cost information, but we will share that with you as soon as it is available. Emily, do you have anything to add?
We should be posting the cost information probably next week is when we'll be able to provide the registration link. And yeah, we're hoping that we can have some abstracts. We'll have e-posters on the virtual platform so that everyone will be able to see them there.
Yeah, that's awesome. I always love seeing the posters and seeing what other sites are doing with their data. I think it's important seeing how other hospitals and programs are using the data that you collect every single day. So if you have a project that you've worked on at your site, please consider submitting that for abstract submission and also for a poster presentation. We would love to have your poster on the virtual platform. Next slide. So like I said, this AQO is a meeting that is all about you. It is all about information that you can glean from the program in order to do your job and drive quality at your center. So we wanted to ask if there was any specific educational content that you would like to see at AQO. Anything that you would like to learn more about, something that you would like to have presented. And so we've included a polling question for today. So I'll go ahead and launch that right now, and you can just type in any kind of ideas you have for educational content that you would like to see at AQO. It's helpful to us to know what you guys want to hear and what you guys want to learn about. So anything that you can provide will be helpful. Because like I said, this meeting, AQO is all about you. We'll give it a little more time because this is a short answer question, so you need time to type. I wish we had some music.
No.
Jeopardy tune or something.
While everyone's thinking and typing, we do have one question about AQO. Do we know if Intermacs session is morning or afternoon on September 23rd?
I'm
So-
not sure if we decided at exact times yet. Emily,
Yeah, in the past, we've started the session at 10 a.m. Central Time, so that it starts at 8 a.m. on the West Coast, and then we don't want it to be too early for those folks. So I think we will probably start it around that same time as we've done in the past, and then it'll go all day into the evening. So we'll have a couple breaks in between, but we are trying to have a good amount of content. If you're not able to join for the entire thing, all of the session will be recorded and it'll go up onto the virtual platform. But attending the webinar portion, our speakers will be there. You'll be able to have questions answered by our speakers at that time.
thanks, Emily. Looks like we've had about 16 people answer, so that's great. I'm going to go ahead and end our poll. Let's see, we can't. So I guess what will happen, Emily, will we be able to see these answers?
Yeah, we'll see them on our end, and then if you press view details, it does pull something up on your end, I think.
Okay. Let me stop sharing.
It pulled up the responses for me. I could share them if you want me to.
Yeah, can you share them because I can't find.
Sure.
Let me stop sharing, Emily.
Alrighty. Here, I will share my screen.
Thanks, Emily.
Yeah, no worries. Okay. Screen. This one. All right. All right. Can you see this? Oh, wrong thing. Can you see this?
Yes.
Am I showing the right thing? Okay. It looks like some of the answers are answers to all the FAQs updated more, resources for adverse events, easier, more streamlined access to data definitions, FAQ, AE definitions, clinical interventions used to support Intermacs profiles such as VA ECMO, etc. Scenarios related to infection, joint commission, pulling of data records, abstraction help, how to get reports. Let's see what else. More education for hemolysis and right heart failure. Further defined definitions. Cardio help, RVAD versus ECMO, RVAD usage. How to maybe discussing automation of Intermacs fields, how other centers are automated the data being pulled for the EMR, and another one for Joint Commission.
All right. Those are great suggestions. Thank you, everybody.
Thank you.
Yeah, we
I'll stop
appreciate your
sharing.
suggestions. For sure, it's very helpful for us as we plan the agenda for you guys.
Very good.
Yeah,
I'll
this is
stop
great.
sharing.
I feel like we should be able to touch on almost all of that.
I agree. I agree.
Do you see me sharing?
Yes.
Okay.
Yes.
So here is our contact information. If you think of something after this call or you need clarification on anything, feel free to reach out to Nancy or myself, and our contact information is there. I think that's it. Thank you so much, everybody, for joining. We will be back with our next webinar on June 25th. And if anybody is interested in sharing any quality improvement projects you have done at your site or you are doing, we would love to hear from you on a future webinar. So let us know. And thank you, everybody, for joining, and have a nice rest of your afternoon.
We do have just one more question about the virtual platform.
Okay.
Will the virtual platform be available for a while in case we can't log in on that day? Yes, the virtual platform is usually available for several weeks after the conference. So that will be available and you can watch the recordings from there.
And you'll be able to claim credit for 3 months. So I just thought I'd mention that we are offering CE and CEU credit. But you'll have to fill out the evaluation for you have a window of 3 months after the conference. So you'll have access to be able to see the content for longer, but only able to claim credit for so long.
Thanks,
Thanks.
Emily.
Yeah. Thanks, guys. Thanks, Patricia. Thanks, Nancy. Great job.
Thank you, everybody. Have a good afternoon.